Okay, my name is Caroline Homer. I'm midwife and co-program director of maternal, child and adolescent health here at the Burnet Institute. And it's my very great honour to mistress of ceremony this wonderful International Women's Day event that we are holding a little bit early than the proper event, which is next week. To start with, I would like to acknowledge the traditional custodians on the land of which Burnet is located. We are on Boon Wurrung and land of the Wurundjeri people of the Kulin Nations, and acknowledge traditional owners past, present and emerging, and any Aboriginal and Torres Strait Islander people here today. And I recognise the important ongoing connection to land, waters and community. Today we come together for a day of celebration. It's great to see so many people online, and we're going to try to, before we begin, to take a photograph, which may or may not be a success. So I'm going to ask you to put your cameras on, and Julie and the team are going to try and take a photograph to commemorate our very first International Women's Day global event. On Zoom, and I think people have got posters. Excellent. Look at you with your posters. That's wonderful. So we'll ask you to put up your posters and a big smile. I don't have a poster. And we're going to take some photographs. So Julie, I'll just stop for a moment. So a very big welcome to you today in this new way of communicating. It does feel a bit weird and it's very different, but I know that we're going to make it work just fine. Thank you to many of you who are joining us as past and current donors and supporters. A huge welcome to those joining us for the very first time. We really appreciate the support of everybody online today. It's really wonderful. We have a number of people with us who have been part of Burnet for many years, and a number of people who've been part of the board of Burnet in the past. And a special welcome to Mary Padbury, who's our current chair of the board, who's joining us today. A big welcome to many of our staff who are also with us. When we hold this event face to face, we cannot fit everybody in the room. And so very many staff are unable to come. But using this platform, all of our staff who identify as women have been invited, and it's lovely to see so many of them here with us today. A special welcome to our teams in our overseas offices in Papua New Guinea and in Myanmar, and to those who live in other countries and work with the Burnet, including our friends in New Zealand. We're a very multinational group today. And our team in Papua New Guinea have already sent us some photographs of them dressed in purple, ready for this morning. So it's lovely that you could be with us. Just some basic housekeeping. I'm sure many of you are experts on the whole Zoom world now, but please stay on mute to avoid any background noise. If you hear background noise from my end, it's my grumpy cat. And I will do my best to be on mute as much as possible. Please use the chat function. Julie will be managing that. And if you have any questions, please put them there. Sometimes it's hard to remember at the end if you have questions, but I will go back to that list right at the end. This year is obviously very different. I was reflecting this morning that our International Women's Day lunch last year was probably the last time I was in a room with more than about 5 people. And I've probably only been in a room with that many people a couple of times since. Bizarrely, last year, our focus was on vaccination, and our keynote speaker was Margie Danchin, who spoke about the importance of immunisation for women and girls. Who would have thought that of 12 months later, vaccination is on the top of our minds, many of our minds. And I saw on social media yesterday that Margie has received her first dose of the COVID vaccine as a health worker on the front line. I bet she didn't think that would be what would be happening in 12 months' time. What a year it has been between International Women's Day events. The theme of International Women's Day this year is about leadership and the critical value of gender equity in ensuring a better world. We have made progress, there's no doubt, but there's a long way to go in terms of leadership. Women's political representation globally has doubled in the past 25 years, but still this is only 1 in 4 parliamentary seats around the world are held by women. Out of the 500 chief executives leading the highest grossing firms on the Fortune 500 list, just 7% are held by women. Of the more than 500 winners of the Nobel Prize, only 53 have been awarded to women. And only 24% of the people that we all hear, read about, or see on the newspaper, the television, or the radio news are women, although that might be a bit different this week. In the 92-year history of the Oscars, only 5 women have ever been nominated for the Best Director award category, and only 1 woman has ever won. These are astonishing statistics collated through the United Nations. I was also struck reading Sam Mostyn's excellent piece in The Age this morning. She highlights how it seems that we in Australia are stubbornly resistant to gender equality. As a country, we seem to be still waiting for proof that gender equality advances society as a whole. She writes of the disparities between men and women in Australia, including the rates of full-time work participation, the time spent in unpaid work, the superannuation system, and in general, a national gender pay gap of almost 15%. And I know those statistics are worse in our neighbouring countries and with our overseas teams in Papua New Guinea and Myanmar. The economic pain of the COVID recession has not been shared equally. Women have been far more likely than men to lose their jobs, more likely to do unpaid work, less likely to get government support. And the effects of this will further deepen the existing economic gaps between women and men long into the future. There's really strong data now that there are huge economic benefits for all countries if women's participation in the economy is equal to men's. This is not a hypothetical, this is real, and we know it's real. We absolutely need to keep fighting for this to happen. We are definitely not there yet. At Burnet, our focus is on equity through better health. We have seriously pivoted very quickly in this last year, working from home, flexible working, schooling at home, while around 50% of our staff have been working on COVID-19, and everybody has been affected. It's been huge for us, and I know it's been huge for you. Today, you're going to hear about 2 distinctive projects at Burnet that have worked particularly around through the COVID period and are particularly addressing women and girls. Thank you for sharing your experiences through the pandemic with us in our survey when we invited you to this event. I really enjoyed reading about the diversity of experiences, and we may, if we have time, come back to some of those at the end of the day today. Interestingly, many of you wrote of feeling fortunate that despite all the difficulties and challenges, there were silver linings. Time to slow down for some, time to connect with your neighbours and your local area. And for some of you, interestingly, a change in stereotypical gender roles with partners and grown children at home more, and everybody in the same situation. As well as today being a celebration about women and women's leadership, it is, of course, a fundraising event. And funds from today will support Burnet Institute's work on COVID-19 and our work benefiting women and girls. I'm delighted to share with you that a group of very generous donors have already pledged $20,000. So you could donate today, and let's try and double that gift. I really want to send a heartfelt thanks to our donors, Frances Wood, Amanda Reed, Marlene Krell, and Dr. Jerry Cohilia, and 2 donors who would like to remain anonymous. Thank you so much for supporting our work. Okay, enough from me. To begin, we're going to start with our keynote address, which we're incredibly honoured and delighted to have. Really would like to welcome Professor Vivian Lin. And I'm hoping Vivian is with us. I can't see her on my screen, but I'm sure she's there.
Yes, I am.
Great. Vivian is the Executive Director, Strategy and Operations and Professor of Public Health Practice at the University of Hong Kong and a Professor of Public Health at La Trobe University here in Melbourne. Vivian is joining us in a different time zone, and we're really grateful for you starting your day early with us, Vivian. Vivian has more than 30 years of experience in public health and a variety of leading roles in program and policy development, health services planning, research, teaching, and a number of senior administrative roles in very complicated organisations. She has incredible international expertise, serving WHO as Director of Health Systems in the Western Pacific Regional Office, where she led on global priorities of universal health coverage and the Sustainable Development Goals. During the COVID-19 pandemic, Vivian has been working with WHO in the Western Pacific on COVID think tanks, as well as the Technical Advisory Group on Universal Health Coverage. She's also a member of the Lancet Commission on Gender and Global Health. Vivian has a very long list of achievements and contributions that if I read out will take most of the morning, so I might stop there, and I'm going to hand over to you, Vivian. Thank you so much for joining us.
Thank you so much, Caroline. And can I please also thank really the Burnet Institute for this opportunity and acknowledge really the fantastic contribution that Burnet and the women of Burnet have made to global health, whether it's maternal and child health, hepatitis, HIV, and of course, all the work that everyone is doing on COVID in this last year. And of course, we are all experts on COVID and women because we all have our lived experiences. And it's really impossible to actually capture either the commonalities nor the nuances and the differences across everyone's experience. But I do hope that I might bring a bit of an international perspective from having had the privilege of being involved with WIPRO and a number of other think tanks in the region during this period. So let me go to sharing my screen here. Okay, so here we go. So on March 8th last year, I actually arrived in Geneva at what was to be the beginning of a 3-week trip, Geneva, US, and Manila. The pandemic was already starting to unfold, and I had to be out of Manila for 2 weeks before going to the Philippines because Hong Kong at the time was seen as part of the Greater China problem. Within a week, I returned to the safety and security of Hong Kong and have been since then observing what happens. And what I've seen and what I'll touch on this morning is how COVID-19 has revealed the fault lines really in all societies, all countries, and across the world. And in this process, of course, women are neither the victims nor the saints, although they also have been both. What has been very interesting for me is the divergent approaches to the management of COVID, despite the fact that the scientists are sharing information. The collaboration has been really rapid. And the evidence has been before all the decision makers, yet cultures, values, politics, governance has led to different approaches across the world. And I want to really argue that as we look back on the last year and think about the future, it is women's leadership that will be vital for building back better, because we cannot return to the pre-COVID era. Because if yesterday led to today, we want a different tomorrow. So the negative impact of the pandemic in many ways has already been well captured with journalistic reporting as well as various research studies. I've mentioned the varying policy responses across countries despite the shared evidence base. The infodemic perhaps is very new for everyone in the world. And through that process, we see quite a lot of loss of institutional trust. And that, of course, has an impact on how well societies, communities come out of it. We've seen hypernationalism including vaccine nationalism. And of course, the border controls, the supply chain issues have all been part of what we have experienced. The increased mental health problems has been very well documented. And while countries have focused their resources on COVID, we've seen disruptions to care in maternal and child health for people with chronic illnesses and so on. And of course, the evidence also says women experience greater exposure as frontline health workers, aged care workers, teachers, and of course, residents in aged care as well. Women have suffered greater job losses and income, starting already with a disparity because of more part-time work, more insecure employment. We've seen rise of gender-based violence in so many places. And when people are working at home, it's the mothers who end up supporting the children through the distance education. So the greater burden of care is not just in the cooking, the cleaning, and the rest. And there's also been reports that, in fact, the male academics have managed to submit more papers in this process compared with the women academics. And that just reflects, I think, the kind of burden that exists. The complexities that we see are both positive and negative. I think initially, it was the wealthy people who went on skiing trips and were traveling and on cruise ships. But then very quickly, we saw how the pandemic reached the more vulnerable in society. Singapore was probably the first in terms of the very large group of migrants, mostly males, in extremely crowded housing. And interestingly enough, while some of the numbers in Singapore have been high, it actually has been very isolated, pretty much in that very vulnerable group. Hong Kong is really interesting. I think you can all appreciate Hong Kong is a very complex society. So with the social unrest, people in Hong Kong wanted the border with China closed. And then when the cruise ship people came back, well, they were the wealthy, they lived on the peak, they had their drivers. So it didn't really spread other than the globally first reported cases of cats and dogs. But then as we moved on in the second wave with the students coming back, and then the third wave, we really saw this getting into insecure employment. The domestic helpers, we've had instances of actually discovering, probably always known, but officially discovered trafficked sex workers who were, of course, extremely vulnerable. And this current fourth wave with a very persistent tail, interestingly enough, has the biggest cluster from the dance clubs of Hong Kong. And these were what we call the tai-tais, or the madams from very wealthy families whose husbands must be, busily out there making money. So they go to dance lessons at the social clubs, but the male instructors and companions are actually in insecure employment. So we had this interesting mixing of social classes. And of course, now we're seeing it in the tenement housing and very poor and crowded housing conditions. So this is the kind of complexity that we see in a place like Hong Kong. But everywhere, it's the insecure employment. And it is the governance that actually matters at all levels of society, both government policy, as well as how public and private sector organizations have moved forward. I think on the flip side, the pandemic does point out the kind of leadership that exists and the level of social capital. There's been extraordinary generosity of spirit and mutual support. And of course, we know so many community organizations are led by women. There have been really active supports for local businesses to try and keep them going. Some countries were learning desperately from history and talking about that history. In Samoa, the swine flu epidemic of 1918 actually led to loss of 1/3 of the population. And the health workers and the women, because they are very important in Samoan society, really try to get everyone to remember and learn from that history. In many Asian countries, it was the 2003 SARS experience that was very important in the way that the communities came together. We've seen new models of extending healthcare access and health protection, and the digital health developments in China, in Philippines, with the kind of outreach at primary care in Korea, in Thailand. There are many notable examples of innovation, both using technology, but also low resource and really building on community structures. And of course, we've seen our chief health officers in Australia taking a more significant role than they might have been in the past. We've seen our researchers and our epidemiologists come to the fore, and there are quite a number of prominent women around in that. So in terms of the positives of the pandemic, we can also see at the larger level a decreased carbon footprint. That obviously raises the question of how are we going to address this in the future. The accelerated digitalization meant new business models, new ways of working, new forms of healthcare access, and in some ways raises the interesting question of how do we capitalize on this fourth industrial revolution? And just as, you know, washing machines and vacuum cleaners transform women's lives in a previously era, how do we actually really make use of it towards gender equity? And maybe workplaces will now finally accept that it is possible to have flexible modes of working and possibly even be happy and more productive at work for some. On the health side, interestingly, women are testing more. And that's at the global level, which may mean that they have less severe illness and less likely to be hospitalized and experience a lower death rate. And in terms of protective behavior, women also are adopting that more and therefore putting themselves less at risk. And this is all despite the fact that women are very much on the front line. And of course, we've seen reports that the countries that do better have women leaders: New Zealand, Germany, Estonia, Taiwan, Norway, Denmark, Finland, Iceland. I could go on. And the flip side, of course, we know would be Trump, Modi, Bolsonaro, Boris Johnson, Putin, Duterte, and we can go on there as well. So at the beginning, so as I said, I was due to be in Manila at late March last year, but what I found myself doing by early April was to be involved with the Future think tank. And the question that WHO wanted to address a year ago was, what's the future going to be like if it's going to take 18 months before the vaccine is ready and out? What will be the scenarios if people have to be in and out of lockdowns all the time? And what can the WHO do? What should the WHO do to support the member states in this? And so it's interesting to look back on the work we did a year ago, because we came up with 4 scenarios. We thought quite a lot of high-income countries with the vaccine, with the scientific, and the resources in the health system could return to a pre-pandemic pattern of economic growth. But there could be another group of countries that will have difficulty managing, so will be on and off lockdowns. There are some countries we felt were not only politically fragile, but their health system was extremely fragile. So we could imagine a system collapse in some of these countries. In others, we thought it would be very uneven developments where some segments of society would move forward and potentially benefit, and others would just manage to muddle along. I think it's interesting 12 months later to see that, in fact, all those scenarios exist. And the question we asked at the time, when people had hopes about going back, is, do we really want to go back? And then if for those countries that had the on again, off again, and I think people in Melbourne could probably, relate to this, is how do we actually sustain that community resilience? And how do we get the government to be responsive? Because it takes a certain kind of coercive government to do this. And for those really fragile countries, and Philippines and Papua New Guinea might be two we might think about in the region with very fragile health systems. How do we support those countries and the vulnerable communities through that and help them rebuild? And if we were trying to get societies, communities, governments to really pay attention with a future-oriented approach, can we recommit and accelerate towards the sustainable development goals? So that really then, I think, takes us to the question of what are the transformational possibilities? And so here I want to talk about the place of women's leadership. Now, studies in different countries, and there's quite a lot, so I won't go into the details, but just highlight, actually have shown that when we have women as leaders, it actually correlates with girls' ambitions for education and employment. That women have been able to help conclude peace agreement more readily, and that when women are leaders, the prioritization of issues are different. So this speaks to women's leadership at different levels. Of course, the way in which women leaders exhibit their form of leadership, as well as their opportunity for leadership, does depend on how each society looks at gender roles and the role of socialization, the kind of structural barriers in place, and the role of agency. But there have been also some interesting studies. So in one study of 175 countries, looking at, do women leaders like New Zealand lead to lower case fatality rates? And the answer is no. In fact, there isn't a statistical difference in COVID-related fatalities. However, the better management in these countries led by women actually reflect a culture of having women leaders. And so the national cultural values really do matter. And then in other studies around public and private sector management, what they found is that both men and women employees value the way during the crisis, women leaders focus on relationships. So they're listening more, they exhibit more empathy, they collaborate, they emphasize team, they try to motivate. So the women managers have scored better than the men on most leadership competencies during this pandemic. And in the analysis of 122 speeches by women leaders, it was also found that the men tended to use much more words around fear and the war analogies, while women talked about social cohesion and compassion. So I think even though national cultures are different, we can see what is at the core of human values. So if we're thinking about the reset, later this year, next year for some countries, I think we need to learn from the failings and successes, as well as really work on that shared vision for the future. Because I think A better tomorrow is also at the most utilitarian value of preparedness for the future challenges. We do not want to see these fault lines revealed again. And so we need to incorporate women's voices. We need to cultivate women's leadership roles and support women's leadership development so that young women can become future leaders, and be at the table of decision making. And we have to incorporate into our policy and program designs the gender analysis and better response to gender inequalities. But more broadly, on this vision for the future, I think it's about a safe and just communities for all. It's women, it's ethnic minorities, it's people who are disadvantaged in lots of different ways. It's really everyone. So equality by design will benefit all. And this is the importance of an intersectionality perspective as a foundation of how we move forward. And we have to move from this fear of other to appreciating the underlying unity of the planet and humanity. So we have to also address the fundamentals of economic insecurity and not just feel good about each other. And so we need to really co-create a kind of workplace that works. We need to think about universal basic income. We need to equalize the digital divide and think about how we harness our resources for a different world. Now that is a very big agenda, and you'd say, okay, but like, what am I going to do while I'm waiting for the revolution to happen? So in the meantime, I want to thank all the women scientists who've been involved in working on the pandemic, on all the different aspects of the disease, because the vaccine is something that is concrete, that is tangible, that is being rolled out, hopefully in an equitable manner that recognizes the real needs in society. And without the contribution of the women scientists, the vaccine would not be possible. So happy International Women's Day. Thank you.
Thank you, Vivian, so much. That was really fascinating, very interesting hearing about Hong Kong and your region. And I never thought about the dance lessons and the dance halls, but that's very interesting. But more seriously, I think the issue of insecure employment is certainly seen around the world. And I really liked your comments at the end about a safe and just community for all, and ensuring them equity, especially in vaccine distribution and availability. And I know that's an area that we are very concerned about as well. And we have colleagues on this call who are working in this space. So thank you so much. I'm going to come back to you at the end with a question from one of our people joining us about global health partnerships. So I'll come back to you with that question in a little while. Thank you so much, Vivian, again, for a really terrific presentation. And I guess one of the really benefits of COVID is that we all do Zoom now like this, and we can have someone from Hong Kong and not even, don't have to fly, and we can not worry about the carbon credits that you would have been using to get here. So it's really terrific. So I'm going to move on to our next presenter. Next presenter is one of our researchers at Burnet, Elise Wilson. Elise is a part of our group, the Global Women and Newborn Research Group, and a great colleague to work with. Elise is also a PhD student and has been doing work in Papua New Guinea for some years. But in this presentation she's going to share with you is sharing some work that we've done at Burnet, looking at the impact of COVID on pregnant women in Australia. And I'm sure you'll find it really interesting. So over to you, Elise.
Thanks, Caroline. I'll just share my screen. Okay, can everyone see that? Nodding? Yeah, thanks. So good afternoon, everybody. Pleasure to be here. So my name is Elise, and as Caroline mentioned, I'm working in the maternal, child and adolescent health program at Burnet. So today I'm going to present some findings from a study that we conducted last year during the first wave of the pandemic in Australia, looking at women's experiences of maternity care. And I'd just like to start by acknowledging traditional owners of the land on which I'm on today. So the land traditional owners are the Wurundjeri people of the Kulin Nation, and pay my respects to elders past, present and emerging. So before I start, I can't not thank the amazing team that I had the opportunity to work with during this study from multiple different institutions. It was a national study, so it was great to be involved with people from around Australia, and of course facilitated by Zoom. And it's important to acknowledge the women and their partners, the maternity care providers and students that also generously took part in the study. And as Caroline mentioned earlier, I know that a lot of people that are joining us today also shared some of their experiences being pregnant or having a baby during the pandemic, and talked about some of the challenges of that and also the opportunities. So thank you so much for sharing your stories with us and for joining us today. So the study overview. So we wanted to look at the experiences of both receiving maternity care, so for the women and their partners, but also providing maternity care, so the midwives, the obstetricians, and also midwifery students. And so we recruited participants mainly through social media, so Facebook and Twitter, parenting groups, professional bodies, professional colleges. And as I mentioned before, it was conducted during the first wave of the pandemic. So there was a national survey online from May to June. And then we also offered people the opportunity to take part in an interview. So there were some interviews that followed, which of course, due to public health restrictions, were not conducted face-to-face, but were conducted over Zoom. So we had a huge number of women take part in the survey. So over 3,000 women responded, and that these were across all states and territories, rural, remote, metropolitan areas. And they spoke about this big shift in pregnancy care. So from usually seeing their midwife or their obstetrician face-to-face to having consults over the phone or via video conferencing. Women talked about lots of changes that were happening in regards to where or how they could give birth. So some women may have planned to have a water birth, but then due to some of the restrictions that came in, they were no longer able to do that. They also, they spoke about not only having to work within the changes from the health system, but also driving their own changes. So women spoke about perhaps being planning to go through the public maternity care system, but then wanting to really have certain people present during their labour or birth, and so choosing to then have a home birth. And so there's these lots of changes that were happening. About 3/4 of women that responded to the survey said that they were able to have their support people with them during labour and birth. So that was, and then in terms of the postnatal period, though, there was quite a difference there. So only less than 1 in 10 women were able to have who they wanted present after birth. And this was both in the hospital, so on the postnatal ward, there was lots of restrictions around visitors, but also then, of course, the public health restrictions and the lockdowns, which limited visitors to the home, meant that women were able to have who they wanted to have at home as well, and visiting them after birth. So some of the other things that women mentioned was so this need to accommodate change and drive their own change. But also many spoke about the experience that they had wasn't the experience that they had hoped for, that the experience that they had wanted. And so here one woman said she was absolutely heartbroken not being able to have her mum there, and she had to grieve for the birth experience that she didn't get. And this is because in many of the health services, women were only allowed to have one support person present. And so they often had to choose between their partner or their mother or an auntie or a cousin or a close friend. And so then feeling like they weren't able to have the experience they wanted. Things like, you know, that we might take for granted pre the pandemic, like having a photographer in the room or something like that, women were no longer able to have those sorts of people there to capture their birth experience. Women also talked about feeling distressed and alone. And so there were, in terms of going to attend appointments, often women had to attend alone. They weren't able to have partners or family members at the ultrasound, on the postnatal ward. So even if they could have a partner present on the, or another support person present on the postnatal ward, in some hospitals, there was restricted visiting hours. So someone might only be able to stay for 2 hours. And apart from that time, the woman would be there, of course, health providers around in the hospital, but maybe by herself. So this is from one woman who said that, so 1 hour after I had my baby, my wife was told to leave. She was not allowed to visit us at all at the hospital, despite being my baby's parent, and no visitors were allowed at all. It was traumatizing. I had a challenging time mentally during the labor, and then my only support person was told to go home and be away from me and my child. It was awful. However, it wasn't all doom and gloom. There were many positive experiences as well. So women spoke widely about some of the silver linings of the restrictions. So it meant that there was more time to bond with their baby and to recover post the pregnancy and birth. They spoke about having more time on the postnatal ward to get advice from midwives to learn about breastfeeding and caring for their newborn. And some women even said that they would support a permanent move to no visitors in the hospital. So there was certainly some silver linings that women spoke about as well. When we interviewed women, so we interviewed 27 women across Australia, and there were similar factors that were mentioned. So the difficulty in navigating an ever-changing system, the new experience of having care behind a mask or behind PPE. So, you know, and in some hospitals there was healthcare workers would have a picture of themselves laminated hanging on their uniform so that a woman and their partner could actually see what they looked like behind all the PPE. And again, women talked about this isolation of having a baby during COVID. We asked women to tell us their three words which described their experience of having a baby or being pregnant during COVID. And so this is like a mind map or a word cloud. And so in orange are the words that were most commonly mentioned by women. So out of over the 3,000 women and the words that they chose, these words came out most commonly. So you can see they're anxious, isolated, lonely, uncertain. And I think we were all very uncertain at the start of the pandemic. And particularly for pregnant women, we weren't really sure about the effects of COVID at the start, and we know a bit more now. But so there was a lot of uncertainty. So not only was it hard for women and their partners, but it was also really hard for doctors and midwives too. They were having to navigate these changes in the health system and didn't always feel that they could provide the care that they wanted to women. But they also spoke about this great cooperation and working together. And you know, in Victoria, we had this, you know, about working together and staying together and so forth like that, and keeping apart. And this has also sort of resonated with the doctors and midwives too. They also spoke about this sense of being in this together. But this sort of follows on from what Professor Lynn was saying before as well about how do we build back better. And so there's no doubt that the pandemic has had major changes on maternity care and substantial impacts on women being pregnant and giving birth. And the new normal for the maternity care sector is still being worked out, but it's clear that there's going to be some short, medium and long-term changes. And so we need to look at these changes and ensure that our maternity system going forward is agile and resilient and can meet the needs of women. And that's all. Thank you. Thank you very much.
Great, thank you so much, Elise. That's really interesting and very important to understand the impact, what we call the indirect impacts of COVID on women and families here in Australia. And I know many of those stories are similar in terms of pregnancy and childbirth around the world, and the lack of social connection. And I think a good theme from a link to Vivian's talk about social capital and, you know, really the importance of social connection and building social capital when you're pregnant and having a new baby. So thank you so much. And of course, everyone, there's an opportunity to ask Elise questions at the end as well. Please just pop them in the chat box. We're now going to move on to another topic, and I'm going to introduce Lindy Masson. Dr. Lindy Masson came to us from South Africa in 2019 and seemed to have only been here for a few minutes, and then we went into lockdown, and so it's been a pretty weird time for her as well. Lindy does amazing research in South Africa and has been running a study on the impact on family violence and also work on HIV and sexually transmitted infections in South Africa. But during this last period, this last year, she's really done significant work on the impact of COVID-19 and lockdown on mental health and gender-based violence in South African women. And this has been a really tough study to do, not only being afar, being away from her friends and colleagues in South Africa, but also the experiences that women have had in South Africa, particularly around violence, has been very hard, I imagine, to hear about and to be alongside. So, Lindy, thank you so much for sharing your story with us this morning. I'll hand over to you.
Thank you, Caroline. Share my screen. Sorry, my computer seems to be taking a while to respond. Can you see the slides?
We can see the slides and it's still on non-presentation mode, but maybe go back out and come in again. It looks like it's got a bit stuck on something. Yeah. Try again, maybe.
My computer, I think, has had enough of Zoom, actually.
I think a lot of our computers have had enough of Zoom. I think they're all starting to protest.
Yeah.
So it's coming. Maybe it might. There we are. Perfect. Well done.
But oh, hang on.
Okay, now it's stuck on this one, unfortunately.
Are you having difficulty moving it?
It's not advancing.
Okay.
Lindy, if you like, I can try and share my screen and you can just tell me when to click through.
That's a good idea. Let's do that.
Yeah.
Julie, you don't mind?
Yeah, no problem.
Great. Maybe unshare, Lindy, and then we can see you.
There we go.
Perfect. Hopefully, Julie will be able.
I say that it's taking a while to load up on my end. Just bear with me one moment.
I have some quite a few images on there that are quite big files, so I think maybe that's part of the problem.
Anyway, why don't you just introduce yourself, Lindy, and tell people a little bit about yourself before you start.
So hi, everyone. Thank you very, very much for the opportunity to share some of the work that we're doing in South Africa at the moment. So much of our research, or all of our research, actually focuses on African women, and we investigate various socio-behavioral and biological factors that are associated with risk of HIV infection in this population. So I see the slides coming up. So in 2020, we pivoted to become involved in some COVID-19 research as well. And specifically, we started working on a study to investigate the impact of COVID and lockdown in South Africa on mental health and gender-based violence in South African women in this setting. So if you can advance the slides, Julie. Okay, thanks. So as I mentioned, much of our research focuses on African women, and the reason for this is because these women are at very high risk of HIV acquisition. You click forward, Julie. So if you look at the statistics in Eastern and Southern Africa, you can see that in young women in particular, they are at extreme risk of HIV compared to their male counterparts. So the red bars show women, and the orange bars show their male counterparts, and you see much higher rates of HIV infection in the women compared to the men. Next slide. These women are also at very, very high risk of gender-based violence. So in 2020, over 50,000 women and children reported sexual offences in South Africa. And it's actually estimated by our Medical Research Council that only 11% of rapes are reported to the police in this setting. So even though this, 50,000 is a shocking number, it's a vast underestimation of what's really going on. And South Africa is one of the countries with the highest rates of rape in the world. Next. These women are also at very high risk of adverse pregnancy outcomes, including preterm birth. Next. And they're very, very high rates of mental illness in the setting. Next. So as I mentioned, the aims of our work are to try and understand the causes of increased HIV risk and adverse reproductive outcomes in young African women specifically. So we look at socio-behavioral factors, including gender-based violence, and also a range of biological factors like sexually transmitted infections and the microbiome. And ultimately, we aim to use the knowledge that we gain through this research to try and develop interventions. At the moment, we're working on a point of care test to identify women with asymptomatic infections who are at high risk of HIV acquisition. Next. Thanks. So the study that I'm going to talk about in more detail is called the Mucosal Injury from Sexual Contact Study. And we've been working on this study since 2018. We aim to enroll 200 women in total, including 300 adolescents and 100 adults. And each of these women is asked to come into the clinic for 6 different visits, timed around sexual activity. And we're looking at socio-behavioral and demographic factors using questionnaires and also collecting clinical samples to look at biological factors that might explain the really high rates of HIV infection that we see in these adolescent women. Next. The study setting so the study has 2 clinical sites. The one is in Philippi. This is an informal settlement in the Western Cape of South Africa. You can see the star there in the bottom of the map. It's a very densely populated, very poor setting and also very high risk. So in 2019, it was among the top 10 precincts with the highest murder rates in South Africa. And South Africa as a whole has a very, very high murder rate. So it's very, very high risk. Vulindlela in KwaZulu-Natal is the second setting. And this is a more rural community, but there are incredibly high rates of HIV infection in this community. And it's among the settings with the highest rates of HIV infection in the world. Next slide. So I wanted to put in a little bit of detail about what it took to set up the study and run the study in this context. So safety has obviously been a huge concern. My clinic team is based in Philippi. So we have experienced robberies. Other clinic teams have been held at gunpoint. We frequently have to close the clinic and evacuate staff because of very violent protests in the area. So it's phenomenal that this team of wonderful women is so dedicated to the study that they're willing to work under these conditions. Ethically, there were also some important considerations. So the study is about sexual activity in extremely vulnerable minors and young women. So it took us quite a long time to set up really stringent protocol and effective reporting and support systems for any range of different adverse events that we might see in these women. And I've listed a few here, and we've actually observed all of these events and needed to support these women through all of the events in this list here. And obviously also working with the community has been really important throughout the study to get their buy-in and support. And I've shown here a photo of one of the protests in the area, and also some photos of the top right is all of us holding the first file for the first participant that we enrolled in 2019, which was a great event for us because it took us about 2 years to actually set up the study. Next slide. So this is some very early preliminary data from the cohort for some of the women who were enrolled in the first stage of the study. Next. So I've highlighted here some key sexual behavior, gender-based violence and depression statistics that we're seeing in this group of 16 to 19-year-old women, we're finding that less than 50% report using a condom with the last sex act. And this is really mirrored in the very, very high rates of sexually transmitted infections that we're seeing in these women. We're also seeing high rates of gender-based violence and very, very high rates of depression. So 39% scored as having mild depression and 14% scored as having moderate to severe depression. Next. So COVID-19 was first detected in South Africa in early March. South Africa then shortly afterwards entered a very stringent level 5 lockdown. And this was accompanied by the banning of alcohol in the country. And this is quite unusual relative to the rest of the world. And since then, South Africa has been through various stages of lockdown, and they've implemented alcohol bans on 3 different occasions. And I think this has had a really important effect on gender-based violence and mental health in this population. So at the same time as the first lockdown, our University of Cape Town Research Ethics Committee ordered the shutdown of all observational clinical studies. And this is an effort to protect staff and also study participants from COVID transmission. Next slide. So we were really worried about our study participants who could no longer come in for visits because they are an extremely vulnerable group of young women. And we were worried that they were potentially confined in unsafe situations. We'd heard reports that the helplines in the country were receiving extremely high volumes of distress calls. And so we wanted to develop a mechanism to contact these women and evaluate their mental health and also gender-based violence and abuse. So we had about 300 women enrolled in the study at the time, and we were actually only able to contact 54 of them. And we found that of these 54 women, 4 reported experiencing some form of abuse, gender-based violence or threats of violence during just the first few months of lockdown. And a lot of these events were alcohol related. We also found out that a 17-year-old girl who participated in our study was raped and murdered during this time. And this was also alcohol related and followed the lifting of the first alcohol ban. So the community was very, very distressed, as were we, about this event. There were huge protests in the area, and the perpetrator was actually arrested and is currently awaiting trial. We also found that 22% of the women reported having mild depression. And this is actually lower than the rates of depression that we recorded pre-COVID. So it will be interesting to evaluate how these women are doing now after the second wave. And we're able to see them again in the clinic, and we're going to be administering more depression surveys to evaluate how they're doing. Interestingly, we found that most of the women weren't actually aware of available helplines and local NGOs that provide support. And most of the women reported that if they needed help, they would go to the police or to family members, which is reassuring that they feel able to contact the police and that they have family support. Next slide. So there were a number of difficulties implementing the study. So as I mentioned, it was difficult to contact a lot of the participants because many of them share phones or they change phones quite often, and they also move around a lot. So most of the 300 women in our study couldn't be reached during this time. And it was also difficult to conduct confidential telephonic interviews when many participants live in informal shacks and have very limited privacy. There were some positive outcomes though. So we were able to successfully refer the women who reported gender-based violence, abuse, or threats of violence, and they're currently receiving support. And we found that with just regular follow-up from our counsellors, all of the girls who scored as having depression actually returned their scores to minimal or normal. And the woman expressed being very happy to be contacted, and they reported that no one else reaches out to them to check on them, and they were actually surprised that someone cared enough to phone them. So this highlights a real gap in this context. Next slide. Looking at information from other sources about gender-based violence and depression in South Africa, when the alcohol sales were banned, the hospitals found that trauma admissions were reduced. So you can see this in the graph on the bottom right. Around April, you can see the reduction in trauma admissions compared to 2019. However, following the opening of alcohol sales, there was a surge in intentional harm, and this is also what we observed in our study. However, even though the officially reported cases of gender-based violence seemed to decrease, the number of distress calls to the helplines increased dramatically, suggesting that maybe women were not able to access services or help. And importantly, there's a lack of data and publications from mid-2020. So we're not really sure how this situation has evolved over time during the pandemic. Generally in South Africa, there have been very high rates of depression, and 2 of 3 South Africans have reported that their mental health has worsened during the lockdown. Next slide. So where do we go from here? We're finally able to see our participants again because South Africa has now come out of the second wave. So we started seeing them again on Tuesday. And so we'll be checking in with them and evaluating their depression levels and also any abuse or threats of violence or violence. We're also looking at ways to try and raise awareness about available support services in the community. So I've shown the map of Philippi here with the little markers showing the NGOs in the area, and there are heaps of amazing NGOs. A lot of them are quite small, but they're also phenomenal organizations like the Desmond Tutu Health Foundation that are running amazing social engagement projects, including thousands of women. We're also applying for funding to try and implement a combination prevention for HIV in these South African adolescent girls and young women. And this will include addressing gender-based violence and mental health in this group. Next slide. So I'd just like to thank our study participants primarily, our wonderful clinic teams, Celia, Funeka, Noluthando, Hilton, and Nokutula, who administered the surveys, as well as our collaborators at the Desmond Tutu Health Foundation, Burnet, University of Melbourne, and our funders. Thank you.
Thank you so much, Lindy, and well done getting through the early technical difficulties. I'm sure everyone will agree that that's really incredibly important work and very sobering to hear about the experiences of friends and colleagues not very far away, and a very different COVID experience with a very different COVID trajectory. I thought that timeline you presented, Lindy, was really interesting. I didn't realise the alcohol bans sort of came and went and then came again. That's a really interesting approach, and it'll be interesting to think about your depression measures in those young people and what's happened to them and whether alcohol's part of that. But it's just wonderful to see 2 lots of vaccines being rolled out now in South Africa, and let's hope that all happens really quickly. So we'll come back to some questions for you at the end, and I'm going to in a moment hand over to some questions which we already have, which is wonderful. I also just want to let everybody know that these are 2 examples of studies that have been going on around COVID during this last 12 months, but really we have an incredibly long list of really amazing projects, all which have impacted women and girls. Margaret Hellard's been leading an incredible study called Optimise, which is looking at quarantine and isolation, and we know that that's something that we all think about and talk about, and is really important that we give the government good policy advice and guidance around how to manage quarantine and isolation. Heidi Drummer and her team in basic science have been doing great work on vaccine development and the point of care tests. Megan Lim, who's with us today, has been leading a wonderful study about young people and the impact of COVID on young people. I know Lisa Davidson's also on the call, and she's been doing some great work with our colleagues in Papua New Guinea on community communication on COVID. So actually getting messages out into the community in rural Papua New Guinea around COVID vaccine and the virus first, and then the vaccine. But and I can see Leanne is also online, so that's big amount of work happening in Papua New Guinea and in our colleagues in Myanmar, who are a little bit caught up with other difficult circumstances at the moment. And in my own team, we've been supporting the United Nations on supporting midwifery care across the region, and my colleague Rachel Smith, who's online from New Zealand, has been working in that space. And I know I've forgotten some more. The other really important one that I know Rachel Farquhar and other colleagues have been doing is around modelling. We've been looking at the effect of masks, so that the decisions that get made by government about whether we take masks on and off, or where we can go, whether the nightclubs are going to be open or not, which I know is the front of everybody's mind. We've been looking at the modelling work in that space. So really an incredible amount of research. The other challenge for us has been some studies have been impacted, and I think a little bit, as Lindy just explained, with studies not able to start or get going. Certainly that's been the case in Burnet. So some studies have had to go on hold because of the lockdowns, and some studies have not been able to continue because the health services have all pivoted to working on COVID and can't do their normal services or support normal research. So just to remind you, this is a fundraising event, and we do hope that you'll be able to support us. We are supporting today women coming together to support other women and building back a better future. And we really appreciate any support, any generosity that you're able to provide to do this work and to do so much more. Every study that anybody ever does, there's a long list of things at the end that we don't know, that are new studies that need to happen. And so your generous support will enable that to happen. So I'm going to just hand over for a few minutes to questions. I'm going to go back to Vivian because we had a question submitted before today about global health. And Vivian, I just wonder if I could ask you to respond to this one, and I'll read it out. So as we know, the Australia-China relationship at the present is riddled with diplomatic and economic tensions. In your experience, is this true of the partnerships in global health? And how can we best ensure that collaboration, openness, professional exchange are fostered and strengthened to the benefit of both of our nations and to all of our regional neighbours? A simple, easy question, Vivian, I'm sure. Wonder if you have any thoughts.
Yeah, and thank you for the person who raised the question. It is a very, very important question, not only in terms of Australia-China relations, but really global health cooperation, because as we saw, Trump had pulled out of given notice to pull out of the WHO. And it was one of the first acts of Biden as president to actually withdraw that notice. So I think, you know, as scientists, as public health people, we recognize the importance of information sharing in terms of learning lessons across countries, in terms of working together, because really diseases know no borders. We've seen the pandemic in terms of a communicable disease, but when we look at things like tobacco, you know, we see that it's the multinational corporations and their interests and their global trade interests, which are also spreading across the world. So this is really, really important issue in terms of global health cooperation. Now, I think the US-China geopolitical tension really has been going on for a long time, and it's important to situate the Australia-China relations in that. And without, you know, wanting to get into a really long conversation about international relations, I think for a long time, Australia managed to look at its own interests and how does it maintain a friendship, a trade, a collaboration with China as well as the US. But the situation has shifted. So I come back to perhaps a public health analogy. And those of you who worked on HIV and drugs will appreciate, you know, when the notion of harm minimization first came up, it was like there was a certain framework in place that criminalized drug use, criminalized sex work. But public health work, people were able to say, for the good of public health, we take a different approach. And we actually separate the public health objective from perhaps the government's other objectives or other sectors. So I think we need to maintain this view that science takes a long time. The cooperation globally is absolutely vital. The speed at which the world scientific community has been able to come together on COVID really builds on some of the investment that happened during Ebola and the different platforms for vaccine development. So it's not a one-off disease, it's not a single instance, but it is this continuous development. And so we have to work really, really hard to really put that global health cooperation at the fore and let the politics play themselves out. But also to encourage our politicians to recognize that you can separate them and you do not have to ask every single institution to just fall in line with your policies at the time.
Thanks so much. Thanks, Vivian. I'll come back to you with another question in a moment, but I think that's really great. And I'd just like to thank Belinda Collins, who's put in the chat about Melbourne punching above our weight. And I think that is because of the collaborations and that partnerships that you've just mentioned, Vivian. Our teams have worked really strongly with people at the Doherty, people in the health sector, at the Alfred just next door to us, and then globally as well. And I think that's a really good example of that. I might go to a question to Lindy about, a colleague has asked about programs for men who choose to use violence in your context. So clearly gender-based violence, I guess for the most part, is perpetrated by men, and whether you're aware of or know of any programs in South Africa specifically addressing that area. Lindy, I don't know if you're still online, maybe not.
I think Lindy is on mute.
She's on mute. I can't see her. There you are. You can't go off mute. Okay. Your computer really has had enough of Zoom, hasn't it?
Can you hear me? I think I'm going to have to update Zoom or something. I don't know. Sorry about that. But yeah, I mean, that's a very important question. And I think a big gap in a lot of the programs currently ongoing in South Africa. A lot of the intervention and engagement programs have focused on young women. And this has been feedback that has been received, that there needs to be more engagement with the young men early on, as well as the partners of the women. There are a lot of activities going on, like the Men as Partners initiative, and these involve, workshopping with men around gender equity. But I think, that's one of our plans as well for the intervention study that we're looking at trying to get.
You've gone back on mute.
There we go. Yeah, so we're at the moment looking for the program that we're trying to get funding for will include the male partners as well.
Fantastic. Clearly, both areas are really important, and this is a very important piece of work, not only in South Africa but in other countries. Belinda has asked a good question, and I'm going to ask Vivian if she would respond about the challenge for women continuing their careers through childbearing years to reach positions where they can lead and deliver impact. Vivian, have you in your travels seen any innovative programs around the world to help keep women in careers through this period, in science, but in other areas?
I can't say that I can point to evidence that there is a gold standard program. Because I think it's not a programmatic approach alone, but it's it's a multiplicity of factors. I mean, I think when we think about younger people who are doing lab work, it is very difficult. And maybe there are some lessons to be learned through this pandemic for both the young men and women who cannot turn up to labs and what it actually means. And maybe there are some lessons to be learned for people who are in more leadership positions about what it's actually like to be unable to actually perform at your usual level. But I think at the institutional level, there are questions about how does promotion actually take account of this particular period of childbirth and child rearing. It's not just having a maternity leave and then you're finished. And I think that's something that's incredibly important across organizations. And it's important for leaders to recognize that, as well as having the policy. Now, having been on the New Zealand Tertiary Education Committee's, what they call the performance-based research funding exercise, or the equivalent of the Australia, I think it's now called the Research Excellence Framework, there is a very conscious approach because the assessment is done at the individual level rather than just institutional, of actually getting people to report breaks and other extraordinary circumstances in their careers. And I know the NHMRC also, has that kind of thing. But I'm thinking that something like a more explicit recognition of a larger research assessment exercise framework is actually also important. So it is a kind of a question, I think, about making sure that every step along the way, we do think about how do we build this in. And perhaps, as we adopt more fluid approaches to marriage and parenting, we will also start to recognize that parenting is everybody's role and not disadvantage the women.
Yes, thank you, Vivian, so much. I absolutely agree about that last point, and there were some comments in the comments that people sent us in about how being all at home together had changed some of those gender stereotypes, and I thought that was really interesting. At Burnet, I'm the chair of the Gender Equity, Diversity and Inclusion Committee, and we're really very cognizant of the issues, especially around promotion and the opportunities that women lose if they're away from the workforce for a little while. We call it career disruption. And I'm also part of the NHMRC's Women in Health Science Committee, and we're really considering this a lot every time we meet and trying to develop policies to support women. I think what you said is very true about, it's not the maternity leave, the 1 year that you might be away, or in some countries, many less months. It's the next 18 years that's a career disruption or a benefit as well. So I think these things are much more complicated. So thank you so much. We do have a question that I'm wondering if Margaret Hellard will be able to join respond to. I know she's on the phone and she may be in a position where she can't, but there's a question about being able to have the vaccine, and someone has written into us who says they have an autoimmune condition and should they be concerned about having the COVID-19 vaccine, whichever one is available to them. Margaret, are you able to speak to that at all?
Yeah, I've just pulled over. So
hi. Wonderful. Thank you so much.
Thank you. No worries. So what I'm going to not be able to answer it specifically. I'm sorry, I've got background noise. I'm literally in the car. So far, the vaccines are showing to be very safe. And I would have thought also due to and Heidi, I don't know whether Heidi's on the line, so she might want to answer this as well. But due to the nature of the different vaccines, I would have thought that if one vaccine is more likely to cause a sort of an immunogenic or a sort of an immune type of reaction that might be not as great potentially or theoretically for somebody with an immune disorder, autoimmune disorder, that some of them will be much better for that as well. So there's ones where it's the nature of how the vaccine works in terms of it being the adjuvant is less likely to provoke that kind of immune response. It's far more specific. So my short answer is, so far the vaccines are looking very good and very safe. And even within the set of vaccines, I suspect that they will be looking at whether there's one vaccine in particular, the Covovax vaccine, that might be really even better for people who have immune disorders. But if Heidi's on the phone, she's much more au fait with the way the immune system will react to things. But that would be my sort of take on it.
Yeah, thank you so much. So that's Margaret Helen.
Can I just also...
Yes.
Can I make a comment as a woman who has had 3 children and...
Absolutely.
Research. Yeah, I think the point that Vivian was making, and hi Vivian, it's great to have you here, is absolutely spot on. I think so often the assessment of our careers is for the period of time we took off for maternity leave. And, there's an ongoing issue of the assessment of not recognising the time required and the impact of raising our children, which is fabulous because we love our children and we want to have children. But at the same time, it does impact, and we've got to really work hard to have systems to ensure that when women come back from maternity leave, we recognise that, we have an honest conversation, and they don't get given what I call the dibbly-dobbly jobs of little things because you're busy, that actually get right back in, be doing high-quality work, but at the same time recognising they won't be able to do certain things, other things, because of their children and the raising of the children. It's complex, but I think there's ways to think about it.
Yeah, thanks, Margaret. That's really helpful. Heidi, I wonder if you would like to make any comments about the vaccine, my question, but also more broadly about the work we've been doing around vaccines. I know you're one of the best people I've ever heard explain the whole vaccine story. So I wonder if you're back with us.
I'm here.
Right.
Thanks, Caroline. I really want to thank all the speakers for their fantastic presentations as well. It was really terrific to hear those presentations, and sad to hear some of those stories as well. Just with the vaccines, I'm not sure whether there's been any specific directions on which vaccines people should get if they have particular autoimmune disorders. So I think it's a conversation to have with your GP. But I think what you might want to think about is getting a test to make sure you've actually made an immune response as a result of the vaccination. If you have an autoimmune disorder, that could be something that you would want to talk to your GP about, is actually having some sort of serological test to confirm that you have seroconverted to the vaccine and that you have a level of antibodies in your system that is going to be protective for you. So that's what I would say in response to that, to add to what Margaret said.
Thanks, Heidi. Given you were with us, I think, last year at the International Women's Day lunch, are you surprised that we're sitting here today with photos of people having vaccinations on the social media and a program about to roll out or rolling out?
Yeah, it's absolutely amazing, and it's an incredible international research effort, and not just one vaccine, but to have so many vaccines. I think the challenge now is getting those vaccines to people who are in low and middle income countries who don't have that, a country that can afford to just buy 5 times the doses of vaccines they actually need for their population, and getting the vaccine to the people in those countries that will really need it. Because I think now the challenge is not to just vaccinate high-income countries, but it's to vaccinate everyone around the world so that everyone has a level of protection against severe disease.
Yeah, thank you. I think the phrase that Dr. Tedros is using a lot in WHO is "no one's safe until everyone is safe," and I think that's really true. I saw yesterday on social media that Cambodia in our region has just started vaccinating, and I know we have Helen Evans from our board online today, and Helen is part of the COVVAX group that is working on ensuring that we have COVID vaccines for all of the people in the Pacific region and in Papua New Guinea. So thank you so much, Helen, for doing that really important work. You're welcome to jump in and say something if you'd like, but I don't want to put you on the spot at this moment. I'll keep going then, thanks.
No, I just want to say thanks, Caroline. No, I think it's just incredibly important that we keep up this message about no one's safe till everyone's safe. We're only as strong as the weakest link, because I do think it's very easy for everybody to come together during a crisis And then as things settle or go back to normal, and I'm afraid with high income countries, we'll focus on our own economies, etc. So I think everybody keep messaging just how important it is, not only to keep us safe, but also for humane reasons, that everybody should have access to this vaccine. So yeah, please keep up the messaging, everyone, when you have the opportunity. But I have to say, I'm really pleased with the Australian government, who's really stepped up. And there is a commitment to ensure from the Australian government and the group I'm involved in that we'll make sure there's 100% coverage in the Pacific Island countries, which includes PNG and also Timor-Leste, and then also contribute to some of the other countries in the region. So,
thanks, Helen. And just asking the same question I asked Heidi, are you surprised where we are this time a year from when we met for our last International Women's Day lunch?
Absolutely. I think what's been done, they're coming together globally, and Vivian made that point really strongly. I mean, what terrible term, the ACT accelerator, with all the key global health institutions coming together and working collaboratively, putting aside their sort of territory and their turf and focusing on vaccines, but also diagnostics and therapeutics. We talk a lot about vaccines, but I think we also need to focus on the diagnostics and therapeutics. But yes, I think it's been an amazing achievement.
Thank you. I'm just seeing a note from Evelyn Kavang, one of our colleagues in Papua New Guinea, who's asking about a test in place before getting the vaccine. Evelyn, I think what Margaret was saying was that for people who have a particular condition, an autoimmune condition, they might have a test after they have the vaccine, not before. You don't need to have any tests before you have the vaccine. It's perfectly, no one is having tests before the vaccine. So please rest assured that when the vaccine comes to Papua New Guinea, you and your colleagues should access it as you're able. So I don't see any more questions there, but thank you so much. I'm going to just take a moment to particularly thank Vivian for joining us. I know you're incredibly busy, Vivian, and there's a lot going on in Hong Kong at the moment. We watch the media with much interest, and we hope you're keeping safe and well, and all the challenges that you have as well as COVID to cope with. But thank you so much for joining us this morning. Really, really enjoyed listening to your presentation. And if we were in the room, we would all clap you. But clearly at this moment, we're just going to do it virtually. A big thank you to Elise and Lindy. Really great to hear about some specific projects in very different contexts, in very different worlds. Lindy, your work makes us really realise how privileged we are here in Australia with the context that we have. But, you know, domestic violence is still an issue for us. Last year, more than 60 women died as a result of their partner violence. So this is not something that doesn't happen here. It just happens differently. But still, we need to not let it happen. And Elise, thank you so much. Having a baby is such an important moment in women's lives, and many women, all women, make plans around what's going to happen in the pregnancy and the birth and in those early weeks. And COVID just messed all that up for so many women in terms of their plans. So really important to hear from women and hear from the midwives and the doctors who looked after those women. So thank you so much to everyone. I'd like to finish by thanking Julie Wood and our communications team who pull this all together and make this happen. This was our first virtual online International Women's Day, and would be lovely to have lunch together next year. Let's hope we can. Please keep fighting for women's leadership, for gender equity, for all the things we know we need in our society, not only because it's good for the economy, but because it's the right and proper thing to do. So thank you so much, everybody. Take care, look after yourselves, and we'll hope to see you in another year's time. Bye-bye.